Hello and welcome to my YouTube channel. My name is Yemi. If you're new here, welcome. This is a space where we'll talk about all things wellness in our bodies, physically, spiritually, in our relationships with one another, and also with God as well. Today, we're going to be talking about fertility. If you are interested, please continue to watch. And of course, to help us understand a lot more about that, I have Dr. Amaka here with me. Just so happy to have you here today. Amaka, you do so many things. I feel like I know what you do, but I would love you to please tell us, what you do.
Okay, awesome. My name is Amaka Obi. I'm actually a maternal fetal medicine specialist, which is a subspecialty of obstetrics and gynecology. So not quite an infertility specialist, but in the same sort of specialty training as an infertility specialist. I currently work in the Northern Virginia area as a maternal fetal medicine specialist. So I do see a lot of patients who've gone through the fertility process since I deal with high-risk pregnancies. I'm just, excited to be here. Thank you for having me on the show. I'm a wife, a mother, and of course, a child of the Most High. So
Amaka is amazing. She does a lot for our community, and really and truly, we appreciate you for that, giving your expertise on so many, things, especially with women's health in our community. Is the Infertility Week, just kind of awareness about infertility. But for me personally, I have had so many friends, right? Friends that are going through trying to conceive. To help us put it in a way that we can better understand what is infertility itself.
Okay. Infertility is one of those unique medical conditions, right? Because it's really a couple, not just the man or the woman. If we have diabetes, a couple doesn't have diabetes. They could, but it's an individual thing, right? What your medical issue is. But infertility really is unique because it's a couple. And the technical definition is that it's the inability of a couple to conceive, or of someone to conceive with regular intercourse over the course of 12 months. So you're not using birth control, you're having regular intercourse with your spouse or significant other of the opposite sex, of course, and you are not able to conceive. And so that's why it's unique, because it's a couple, right? You need two people to be together to not be able to conceive for that to be called infertility. So, there are some people, now we kind of put the definition in groups of age. So if a woman is under the age of 35, we say 12 months of regular intercourse without birth control and no conception. If you're 35 and older, the thought is 6 months, right? Because as women get older, as we know, it does get a little bit more difficult to conceive. And so the thought is not to give that 1 year time span. So that is the technical definition of intercourse, of infertility.
Thank you. In our community, right, a lot of times you always hear the woman say that I am trying to, as a woman that carries, most times from what I know, as a woman that carries the burden, it's like, she's not been able to give birth. So I really appreciate the fact that the definition is the inability of a couple, not just one person. Women most times will be the ones out there asking questions and saying, looking for answers and stuff like that. What can we really say could be a possible cause of infertility?
Yeah, so there are many reasons, many things that can cause infertility, starting from hormonal imbalances to having untreated infections or pelvic infections that can cause blockage of tubes and things like that, to, of course, in the male, not having enough sperm, so low sperm counts versus no sperm at all, and to, changes in ovulation where a woman is not ovulating, meaning she's not releasing any eggs, to even, genetic conditions. There are some people who are born and do not have the ability to conceive, and sometimes they don't know that until, as they get older. So there is a wide range of possibilities, and it depends on, when a couple come for testing, then they figure out, okay, what's the problem? And that's from a sperm analysis to, uterine factors, so the uterus is where the baby grows. So if there are issues with that, then that could be a problem. If there's issues with the tubes or having eggs, that could be a problem. So there are multiple things, medications that people take. I mean, that can affect, their fertility. Smoking, alcohol. I mean, there's so many things that kind of play a role in infertility. So there's just some of those things I just mentioned.
Thank you. So really, it's letting out sound like I'm repeating again, but some of the causes you've said, low sperm count, pelvic diseases, maybe untreated STDs that people have had. So in treating, looking for answers, it shouldn't really just be the woman alone. So it should be, it should be a couple thing. Mm-hmm. Okay. All right.
Definitely both people need to be looked at, because even though, like you said, especially in our community or in, African heritage, there's a lot of, responsibility, I would say, placed on the woman, with regards to childbirth, like, why are you not pregnant? What's happening? What's wrong with your uterus? And so we forget that, again, there are two people involved. So in any kind of diagnosis, both people should be screened and tested. And you'll be surprised at how many times it's a male factor and not a female factor. So it's important for couples to remember that.
Some people will get married and 3 months, 4 months, they're already really very anxious, especially in our community, or people around them, maybe in-laws are she doesn't have a child yet. What is going on? And they're just maybe 6 months into this thing. What would you do with someone like that?
Right, so not quite. I think one, it depends on age, right? If someone is 23, just got married, they've been married for, 2-3 months, they just started trying. I don't think that it's quite time for alarm. I don't think that it's quite time for, let's run to the doctor and figure out what's wrong, because we know that a lot in women who are trying to get pregnant, yes, most women, a good number, I shouldn't say most, a good number will get pregnant within the first 3 to 4 months. But really, a lot more will get pregnant 5, 6, 7, 8 months into trying, especially young women. Now, if you're 35 or 40 and you just got pregnant, or you just got married, or you put off childbearing for a long time, even if you've been married for a long time, or you decided, okay, now's the time I'm going to start. If you're in the 4th, 5th month and no conception, I would say, hey, it's time to start, maybe making those appointments, even if it's not to do anything drastic, but at least to go talk, figure out if there's something that, is different, maybe start to work towards the testing. Again, because a woman, as we get older, now we're speaking to women, there's just not that much time, unfortunately. It's just the way that the body is made. And so it's important to start early. And that's why that definition changes from 12 months to 6 months if you're older.
Okay. Thank you. So age actually does play a big, factor, big part of this. Thank you. And I was wondering, talking about age real quick, at what age would you, and now this is speaking as a professional, not as not as a woman of faith, right? At what age would you advise someone? Because I don't know, there are people that are maybe well advanced in age and they're still trying to go through different types of treatment and trying to, they're still hopeful. Medically, at what age would you say it is considered safe to, or when would you tell somebody to just stop trying, if you ever do that?
I'll be speaking from a high-risk obstetric specialist. Yes. And honestly, it's difficult for us to say, don't try, right? I mean, I think that every woman who wants to, not every woman wants to, but every woman who wants to conceive or who wants to, have a child or carry a child, however you translate that. I mean, there are other ways to have children. There's adoption, there's, all these other things. But any woman who wants to conceive or who wants to have a child, we think that should have the opportunity. I think, of course, there are varying reasons why we say, hey, don't do this. I mean, some people have significant medical problems where having a child will be detrimental to their health. So, of course, in those instances, we say, hey, regardless of the age, this is not something you should be considering. But I think if someone's healthy, I mean, we now have patients who are 55, 60. Who are we to say that? Yeah, 60. I think, one of my oldest patients was 61. And so, who are we to say that they can't? Now, of course, it's highly unlikely, in fact, medically unlikely, that you would naturally conceive at the age of 60, right? Because women are menopausal. Average age of menopause is what, 53? So most people, once you're menopausal, there are no eggs. So technically you can't get pregnant. However, you can do fertility treatments. There's IVF, there are other ways to get pregnant at that point if you wanted to. Now, of course, this should be a discussion with your doctor. They send you to, have specialty testing, consultations, just to make sure that, again, because a pregnancy at that age does come with complication. I will not tell you it's not complicated. It can be. Okay. But we never say never, right? Wow. So those opportunities exist. Ideally, it would be better to be younger. It would be better to be healthier because, of course, that's how you get the better outcomes for pregnancy. And for a naturally conceived pregnancy, definitely younger makes it easier. I mean, even by age 41, the rates at which women get pregnant drastically decreases. I mean, from 25 to 41, there's a wide difference. And so, there's no perfect age, there's no cutoff age, but we do have to think about the natural cycle. We have to think about, is this going to be a naturally conceived pregnancy? What kind of health status will I have as I get older? All of those things factor into the decision-making of what's prime time or what's best, right? I think medically, ideally, we would want the patients to be young, 20s, 30s, you're healthiest, you have the greatest fertility during those years. But can you be pregnant in your 40s and 50s? Of course.
Thank you. I was just thinking about, you've already mentioned some of the treatments, and I will still talk a bit about that. But there's a lot of women now because of, hormones, the food that we eat, which is one of the things that I'm passionate about. I'm looking at wellness, how to eat better, exercise, and all this other good stuff. But we have a lot of people that have like PCOS, hormonal imbalance, endometriosis. You can mention, way more than I can mention. What are the hopes of people struggling with things like that in terms of trying to conceive?
Again, you're correct. I mean, women, there's a lot of things that factor into how your hormone state is. And of course, that translates to your ability to conceive, right? Because if things are unbalanced, then you don't ovulate, no pregnancy, and so on and so forth. And of course, things like PCOS can affect ovulation, weight, health. the risk of diabetes. I mean, there's so much that can even affect pregnancy and ability to carry a pregnancy. And so there's hope. Yes, there is increased risk of infertility in those patients or in those people who have these conditions or hormonal imbalances. People do still get pregnant. I think that there are, like you mentioned, diet, exercise, those things are important. Less stress, no smoking, no alcohol. These things are important because we know that these things can affect your health and affect the ability to get pregnant. Take, for example, if a woman is obese.
Yes.
We know that the higher your BMI is in the obese category, the higher the chance of infertility. The less likely you are to conceive with every cycle while you're trying. And so, putting exercise and a healthy lifestyle and a balanced diet can help with that BMI and can help with that obesity, which then can help regulate your cycles, right? And so, I would say that there's hope, and I would say that it would take, maybe reaching out to your doctor, sitting down with a nutritionist, finding an expert who will be able to help you and guide you through, right? Women with PCOS who are obese, they have a lot of trouble losing weight or, trying to keep weight off because, again, the hormonal imbalance makes things even more difficult from that standpoint, not just the infertility. And so, there are a lot of physicians out there, nutritionists who can help guide, your diet, who can help guide an exercise regimen, things like that to sort of get things in process. Of course, there's medication that can, work hand in hand. Things like metformin has been used in these women with good outcomes. There is medications that help women ovulate more, things like Clomid. So again, there are options out there and there is hope. I think it's just, again, realizing, okay, this is what the issue is, this is what the problem is, and then how can we work through it, which is where going to someone, not waiting 3 years, not waiting 4 years, but as the months go by, nothing is happening, taking that time to go see your doctor and saying, hey, what's going on? Can I get some tests? Can I figure out what's going on with my hormones? Can I figure out, is it my uterus? Is it the tubes? All of those things are part of sort of the initial workup for infertility. And so if we don't bury our heads in the sand and we start to ask questions and we start to try to find answers, that's when we can get help, So there definitely is hope.
Awesome. Thank you. As women of color, that fibroid is very, very,
yes.
very, very common. Can you speak to that? Like, why do we have so much fibroid among us as women of color? And also, I know this is like 3 in 1, but I know a lot of people that are very skeptical about when maybe they've recommended surgery for such, they don't want to take it out. So I don't know, can you please speak a little bit about?
Yeah, fibroids are a big topic. And, I think we don't know why African-American women or African women have the highest burden of fibroids. We haven't quite figured that out. I think there are even like studies in process that are trying to figure out why this is. But we do, and they are very common. So we don't think that, yes, there are a few cases where, of course, it can affect the tubes and the uterus and, pregnancy can happen. But for a lot of women with fibroids, they don't even know they had fibroids until they got pregnant. So it didn't seem to affect their ability to get pregnant. So there are a few cases where, yes, it can affect it. But for a lot of women, they get pregnant, they have fibroids. However, there are potential complications with the pregnancy too if you have fibroids. So it's sort of this wide-reaching phenomena or thing, and it's different for each person. So the location of the fibroid, the size of the fibroid. Some people just have small 1 to 2 centimeter fibroids. That's probably not going to be a big issue for them. Some others have 10 centimeter fibroids, 15 centimeter fibroids where, they have issues with intercourse, or they have issues with, growing a baby or keeping a baby, depending on where the fibroid is. So fibroids, as a broad term, it needs to be more specific. It needs to be individualized, because everyone's fibroid is going to be a little different. And so we don't say that it's a specific cause of infertility unless there's certain things that we look for. Is it in the lining of the uterus? Is it blocking the tubes? Is it causing obstruction? Things like that, because a lot of women have it. We say over 50% of African-American women have some type of fibroid. And for most women, they're able to conceive, they have children, it doesn't bother them, they may have heavy periods, they may not even know. So it's a big topic. And just speaking about, whether or not to have fibroids removed, I think one of the reasons why it always is a discussion, an in-depth discussion that you need to talk with your gynecologist about and sort of weigh your options, is because any kind of surgical procedure, if you think about it, can cause, bleeding, and then there are complications from surgery. And, sometimes with a major fibroid surgery, people have had to have their whole uterus taken out at the time. Not to say that happens always. It happens rarely, but it can happen. And so when you're thinking about having a surgical intervention, you also have to think about, well, is this necessary? If the fibroid is not causing infertility, if the fibroid is potentially not going to cause too much of a problem in pregnancy, the thought is, hey, leave it alone. You can get pregnant. Maybe after all of your childbearing, you take the fibroid out. There are a few cases where fibroids are really detrimental to a pregnancy, where they are in cervix or something and they cause problems, or the baby doesn't grow, or someone has miscarriages. But in general, that conversation should be individualized and should be based on looking at the entire picture. So, they do ultrasounds, MRI, talk about how big is it, how is it going to affect things, and how long have I been trying? Have I been trying for 12 months and then nothing's happening? So I really think that it should be an individual topic. It's hard to generalize fibroids because they really are specific to the person and to the location and size and all of these other things. So it's going to be important to talk with your physician and talk with a specialist about what your fibroid means for you and your fertility journey, right? Because not all of them have to be taken out.
Okay. All right. Thank you. As this is a very broad topic, like we said in the beginning, and we could go on and on and on. But and the thing is, from the things that you've said now, that everybody's journey is different and every patient's case is different. Really, the idea of this topic and is to bring more awareness, and especially for our community. I see that sometimes people are so afraid when they're giving some certain, diagnosis, and they feel like, oh my goodness, is the end, this is never going to happen. But this is just to say, breathe, do your research. If you have to do, get a second opinion. Don't keep to yourself, because there are resources, there are people out there that can help. So this is the beginning of, so many things that could be said about this. In talking about treatments, because we're going to be closing out soon. In talking about treatments, I know you've mentioned quite a few, but Clomid is what I want to talk about. Clomid is that one medication. I don't know how people get it in Nigeria, but you please speak to that. Should people really just be going on self-medication, with something like Clomid?
Yeah, I mean, one, I always say no one should self-medicate. I think Clomid or clomiphene is everywhere. And of course, outside of the US, I mean, here you can't just walk into the pharmacy and be like, give me some Clomid. nobody will talk to you. But I know that people, they'll have it sent over or whatever the case. I really encourage people to talk with their doctors. I mean, yes, there are people who need Clomid, and that's one of the things that they, will try first, right? Because it's easier than other fertility treatments and things like that. And it's supposed to help induce ovulation. There are side effects for people. So I would, urge women to seek help and seek someone who can guide you through the process, right? There's definitely increased risk of multiples. I know at least for our people, we're like, twins, triplets, awesome. And it's great. I'm not going to knock multiples, but again, coming from my specialty, I think, those come with complications too. So it's very important that we seek guidance before we just start taking medicine. There are definitely, things that we shouldn't take. What health problems does the person have already? You want to look at those things so that you don't take a medicine that contraindicates something else that you're taking and then put yourself in trouble. So it is a good drug. It does work well for some people, but I think that it's important that you talk to the right person. Your obstetrician, gynecologist is available. That may be harder for some of our sisters who are in, Nigeria, other parts of Africa, where you don't have ready access to a gynecologist or an obstetrician or someone who can sort of guide you through the process. And most people are just picking up from the pharmacy. But I would really ask that you pause, ask questions, even if it's to the pharmacists, right? Because from some of the places we're from, some of those pharmacists have information and sharing with, say, hey, these are my meds. Is this something that's going to be contradictory before we just pop pills? I mean, I think that's definitely important. Clomid has its place, no doubt, and it works well for some people, but I would encourage women to pause, ask the right questions, make sure this is right for you, make sure this is right for your family before you do it.
Thank you. Thank you so very much. Talking about IVF as a possible treatment, there are women that have tried IVFs or had failed IVFs. Mm-hmm. And this is from just speaking, I guess, as a medical person as well, beyond faith. When can someone really give themselves and say that, when do you stop? Like people that have had failed, I know it's a hard, it's process, it's painful, especially it entails a lot of time, money, emotions. But we have people that have been trying and done a lot of IVFs and still no success. To right. Someone like that, even ask them to stop, from right. the medical community, or they keep trying.
Right. That's a great question, and it's hard to answer because, like you said, there's a lot of emotion. There's a lot that goes into IVF, right? Outside of just the medical aspects, the ups and downs of all of these failed IVF cycles, or even ones that worked and ended up, with a miscarriage, like an early miscarriage or something. So it's a hard question to put a stop for someone. I do think that there are some hard stops that will be medically necessary. For example, if a woman is trying, to use her own eggs and, keeps having IVF cycles and is not really making any eggs so that she can, they can be fertilized. At some point, the IVF doctors or the fertility specialists are going to say, okay, we're not, we can't stimulate you anymore. Nothing's happening. That's when they start talking about donor egg. That's when they start talking about outside options, right? So I think the stopping really depends on what's happening. Multiple failed IVF cycles, because you didn't have any good embryos versus, there are different things that happen in the process, I would say. And so it's hard to say, oh, you did it 3 times. There you go. That's your magic number, no more. You did it 4 times. That's your magic number, no more. I think it depends on what's happening. And it also depends on the person's, emotional state, not just the money and the time and all of those things. If something is really putting a lot of stress and drain and, ruining relationships and things like that, maybe it's time to think about dialing back and taking a break. Taking a break doesn't necessarily mean stop. I think, infertility is such, a difficult thing because it's not just medical, psychosocial, there's just so many aspects of it that sometimes, women need to take a step back. And then the stress is not helpful to all of these cycles either, right? And we know that stress affects a lot of things. So there's no great answer to when to stop. I think that should be, a discussion with the specialist, with the fertility specialist, with the family on their own, kind of deciding, okay, we've done this. There are other options available for having children. We kind of mentioned adoption and things like that. So gestational carriers, everyone's journey is going to be a little different. And I think that what's important for us and really is just to remember to be open and to be open to options that are available. I think sometimes people are really focused on, I want it like this way.
Yes.
And they don't want to look at what the other options are. Is donor egg a better option? Is a gestational carrier a better option? Even though that's really expensive. So, there are lots of things. So I just think, the best way is to have an open mind.
Thank you. Thank you so much. That really helps because I feel that for us as a people, we are at a place where we are, we have accepted IVF. There was a time IVF was not accepted, right? So now we're really focused on IVF, and that's where people are stopping at now. And I know you said a couple of things, and because of time, I just want you to give us, if you are talking to somebody that has had failed IVF, and I know that this is, like you've already said, could be for so many reasons, but they want to move beyond that phase of failed IVF. You talked about gestational carriers, donor eggs, adoption, which I feel that is a huge topic, all by itself, that is worth, discussing. Are there any other ways or treatments that could be considered?
Of course, we know that IVF is like high up there on and the ways that you go about that. I think it depends on what the reason for infertility is. They usually start with things like clomiphene and then IUI, which is insemination, and then on and on from there and so forth. And so, those are really all of the options that we have available. And then moving on to, okay, can I have a child through another means? Have someone, carry the baby or adopt a child. And all of these options would really depend on what the reason for infertility is. For men, sperm donors, they have sperm banks, something again that we don't like to talk about, but, those are options. And so, those are the things. And I will tell you that for a lot of couples who start to try IVF, then, it seems like it's not working, or they take a break or something like that. A number of them get pregnant on their own. It's like, oh, oops, look, I got pregnant. And this is something that we see a lot. So, it's not the end of the world. I think that, we sometimes think in the situation that something is not working, it would never happen. And we know that these things happen. We know that, miracles happen. We know that things that are unexpected happen all of the time. So it's sort of that place of just continue to be steadfast and,
Thank you.
having a positive attitude and believing.
Thank you. And in rounding us up, I want you to talk to that woman out there that is tried now as a woman of faith, because I know you're a woman of prayer. And I just want you to speak to that woman, that nobody sees crying at nighttime, the woman that is, so burdened and so stressed and has family members, just beating down on them and asking questions, and they're being called names like barren, and all those just awful things that society can do to us when we go through challenges. Can you please say a word to that woman for me?
What I would say is, yes, we may not be working in your shoes. And yes, those shoes may seem painful and uncomfortable, but, be strong, stay strong. This is not your fault. This is not your battle. Things change. Be confident. Keep your head up. Wipe your tears, because the God that we serve is a good God.
Yes.
And he never forsakes you. He will never leave you.
Thank you.
And he answers. So
He does. He does. Thank you so very much. Thank you for your time. And I want to say thank you to everyone that has stayed tuned and, here watching with us. I really appreciate you guys. Don't forget to share this video. Don't forget to subscribe. And also, if you have any questions, please leave it in the comment section for me. If you have questions for Dr. Amaka, she'll be happy to answer us. Put it in the comment section for us as well. Dr. Amaka, thank you so much for your time. I really appreciate you. Thank you for all that you do for us as a community. And hopefully I'll bring you back soon.
I'll be happy to come back. Thank you for having me.
All right, sure. All right, bye.